Thank you. So luckily Egbert already finished his presentation before he dropped down, so I'm going to present his slides. So it's about the biomarkers predicting from the clinical activity, and I will go into more depth in what the two former speakers have already touched on. And these are his disclosures. So what is going to be discussed are the clinical characteristics, the tumor-associated biomarkers, blood-based biomarkers, and some one slide on the imaging. And what we know from the first trials on the PD-1 treatment was that smokers performed better than non-smokers. And that was seen in the nivolumab trial, but it was also seen in another trial where they saw that smokers had a higher response rate than non-smokers. But in this trial, it was also looked for the PD-L1 staining. So you already heard, and I will go into that in more detail, about the value of the PD-L1 staining. But here they also looked at the PD-L1 staining. So 3 is the highest and 0 is non-staining. And they combined the two. When you look here at the survival curves, you can see that in the non-smokers, independent of the level of PD-L1, there is no activity of the drug. While in the smokers, you can see that when there is the high expression, they do better than the low expressing. So it shows that the smoking has an effect, but also the PD-L1 expression. And this could have to do with the mutational burden, as was already showed, but I can show you here in more detail that when you look at, for instance, p53 mutation, you can see that this level of p53 mutation is higher in smokers, and it's also depending on the number of cigarettes smoked. So high-heavy smokers have a more mutation on that side. And that was also shown in this figure when you see here that lung cancer patients are the ones with the highest mutational burden. So what it says here is the number of mutations, and these are different kind of tumors, and you can see here that in the lung cancer patients there is the highest level of mutations. What's the idea about that? Well, the idea about that is that these mutations can cause neoantigens, so tumor-specific antigens, which are not familiar to the body, and these neoantigens will prime the immune system to start an immune response directed against the tumor. And this was also shown so that in these patients where you have the highest number of mutations, these patients did better on the checkpoint blockade with the PD-1, PD-L1. But it's rather complex. So we think when you saw these cartoons about the activity of PD-1, PD-L1 axis, it's always about the T cells and the tumors. But we know now that this PD-1, PD-L1 axis is also active in macrophages, on tumors, but also peripheral fibrocytes, antigen-presenting cells, and regulatory T cells. So you can imagine that you can stain for it, but you also have to look which cell it does stain for the PD-1, PD-L1. And it was already shown, this is a large study done in resectable lung cancer, and it's rather small, but what you can see here is the PD-L1 negative and the PD-L1 positive, that in the largest case, these patients who had a resectable lung cancer, which was PD-L1 negative, that they did better than the PD-L1 positive patients. And this was also found in stage 4 lung cancer, so advanced disease, patients treated with chemotherapy, those with the negative staining did better than those with the positive staining. Well, then to the two first trials. So this is the nivolumab docetaxel in squamous cell lung cancer, and here they took the PD-L1 staining as the biomarker. And you already saw this figure, but I go into this on behalf of Egbert in more detail. And you can see here they have a cutoff level of 1, 5, and 10. But you have to keep in mind so that the patients who are having less than 10 are also included in this graph because they are having more than 5 but less than 10. Right? So this is more or less than 1, this is more or less than 5, and this is more or less than 10. And you can see here that also in the negative, so the negative less than 1, you can see that the survival of the nivolumab arm is higher than in the docetaxel treated arm, but the difference is higher in the patients who are having a high expression. And that you can see here in more detail. So when you compare just the nivolumab-treated patients and you compare the positive, so higher than 10 and lower than 10, you can see here that there's a difference in survival of 3 months. So the positive ones do better. Regardless, the negative ones do respond and do better than docetaxel, but those who have a positive staining do better than the ones who have a negative staining. And when you look at that in more detail, you can first have the PD-L1 negative and positive, and then you get the same curves. So these are the same curves showing higher and less than 10. And on the left side, you only look at the negative ones, and on the right side, you only look at the positive ones. And then when you then look at the curves, you can see that when you look at the negative ones, so the PD-L1 negative stainings, and you compare the docetaxel to the nivolumab, you can see that there's an advantage of the nivolumab, but it's on the median from 8.2 to 6.1. And when you look at the high expressing patients, then the difference is 11 to 7.1. So again, there is an advantage in the lower expressing, but it's much higher in the higher expressing patients. So this was in the squamous cell lung cancer, but it has also been done in the non-squamous. And you already saw this graph, but what is striking here is the fact that there is a proportion of patients who do worse with the nivolumab than with the chemotherapy. So there's a proportion of patients who are treated with PD-1 who could have better be treated with chemotherapy. And then we come back to these staining figures again, and here you see again the more or less than 1, more or less than 5, and more or less than 10. And when you go to that in more detail, here you can see the more than 10, and you can see that in this patient population there are no patients who do worse. Right? So when you go back to this one, you can see here there are patients who do worse with the nivolumab. But here, the high-expressing patients, none of these patients do worse with the nivolumab compared to docetaxel. And what is also impressive is the difference in the median overall survival. So here we have about 20 months, and here it's only 8 months. So there's a large difference. And when you look separately at the low-expressing, so lower than 10, and you compare that, then you can see that it's almost equal. So in the non-squamous cell lung cancer, it seems that the PD-L1 is predictive for the effect of nivolumab. And then Egbert made a brainwave where he thought, well, where have I seen these kind of curves before? And this is the data from the IPAS study. And you know this were patients treated either with gefitinib or with chemotherapy. And there you also saw that there was a proportion of patients who did worse with the EGFR inhibitor and others who did better. And these look quite similar when you compare this to the nivolumab curves. And you know that when you enrich this study, the IPAS study, for the EGFR mutation patient, then you see the ones who benefit. And when you look at the curves in the higher than 10 expression patients on the nivolumab, you see a similar curve. So the patient selection will work, and probably, although I have my own objections against the PD-1 staining, which Professor Scagliotti also told, I think we can select patients, also to select patients out who do worse with the nivolumab. Well, this is not only seen in the nivolumab studies, this is a study with pembrolizumab where they also did look at the staining, and here they have a staining which can be less than 1, from 1 to 49%, or more than 50%. So the lower ones are called negative, and the in-between weak, and the more than 50% are called strong staining. And when you look here at the curves, you can see in red are the ones who have the high expression, so more than 50%, and you can see that in total there was a higher response rate, but also this was found either patients were previously treated or treatment naive. I will not go into all the details, but it shows you that the higher staining patients did do better than the lower staining patients. And it also yielded into the overall survival. So when you look here, you can see that the overall survival was better in the highly expressing patients and was similar in the lower expressing patients. So it shows you that the PD-L1 expression may be predictive for the effect of the pembrolizumab. And this also reflects into the response rate. So when you look at the cutoff level of the PD-L1 staining for less than 50% or higher or equal than 50%, you can see that when you select patients based on this high expression, that the number of responding patients is about 90%. So you select for patients who will get the response to the PD-L1 treatment. Well, this is a lot of information on this figure, but this is the problem we are having now at the moment. That is that we have 4 major compounds now coming already into the clinic or coming into the clinic. And the disadvantage is that all of these agents use a different assay. So you have different assays, what we call PD-1, PD-L1 positive. And it's also that you use different staining. So some of them look at the surface staining, some of them look at cytoplasmatic staining, some of them look at also the immune infiltrate staining, and also the number of cells calling it positive or negative is different. So based on these data, we cannot compare everything, all these studies, because what you call positive can be different. So that means that there are a lot of limitations now to use the PD-L1 as the ideal biomarker. So for one, we have to define what we call the PD-L1 biomarker, so which platform we are using, which kind of staining, and which thresholds we are going to use throughout the scientific community so that we can compare our data. The other thing is that it is dynamic, so we have to keep in mind that PDL is a response, or could be a response of the tumor or its environment to an effective T-cell response. So one can imagine that when there is an effective T-cell response, the PD-L1 starts to be upregulated. So it's a dynamic one. It can be negative in one instant and can be positive in another point in time. It's heterogeneous in the tissue, and I will show you an example of that later. I also touched on the fact that it can be cytoplasmatic or membranous. Which kind of staining are you using? The quality of the biopsy is, of course, always essential, and also the way the biopsy is handled in your pathology lab can have influence. The importance on the co-localization with the tumor-infiltrating lymphocytes. I will show something about that later. And the honest answer is that we don't know how to handle with a continuous variable as a biomarker, and we need the prospective validation of this biomarker in ongoing studies to know what is the value of this biomarker. And this is a picture from a biopsy where you can see here, this is the same biopsy, and when you look in the top, the PD-L1 staining is negative, and when you look on the bottom, it's positive. So this is the biopsy of the same patient, and even in this small biopsy, the level of expression of the PD-1, PD-L1 is different. Also, for lung cancer, we know that the number of tumor-infiltrating lymphocytes can be a prognostic factor. So here you see in a study in stage 1A lung cancer, so early stage lung cancer, that when there is an increase in the number of tumor-infiltrating lymphocytes, this causes an increase in the recurrence-free survival. So patients with higher level of tumor-infiltrating lymphocytes have a longer survival. And here you see a picture of that where the lymphocytes are in the tumor field. And that's already been touched on just this morning also, that we have to look, probably not only have to look at the PD-L1 expression on the tumor, but also on the tumor infiltrating immune cells. So you can imagine when there is a tumor-associated macrophage, which is PD-L1 positive, it can also shut down the tumor-infiltrating lymphocyte. And what has been done in this study with the Roche compound, there they used a different way of staining, where they also looked at the staining of the tumor, but also looked at the staining of the immune cells. And then they made a score. So they can be both negative, or they can be both 3+ positive, and something in between. So 2-3 or 1-2-3, and then you get combinations of this. And when you look whether this is predictive for the effect of this compound, you can see that this is true. So in the negative ones, there's no advantage of the immunotherapy compared to chemotherapy, but in the highest expressing there is, and also in the intermediate expressing there seems to be a scale that is more effective. So it could be that when you take into account also the infiltrating immune cells and their positivity for PD-1, PD-L1, that this has an effect on the efficacy of your immunotherapy. Another way of looking at this is because you can stain for your tumor-infiltrating lymphocytes, but you don't know what is their activity. You don't know whether these are active tumor-infiltrating lymphocytes or they are already exhausted. So one way of looking at this is that you look at the effector T cells signature, gene signature. So you take a sample of the tumor and you do gene signature profiling for the effector T cells. And when you do that, you can see here that when a patient is having a high expressing effector T cell gene signature, he will respond better to the immunotherapy than to chemotherapy. So it understrikes that you need tumor-infiltrating lymphocytes, but they also need to be activated to be targeted by the immunotherapy. And this is another way of expressing that, is that you combine the PD-L1 level with the interferon gamma mRNA status. So interferon gamma is produced by cytotoxic T cells, so that means that these cytotoxic T cells in the tumor do have a cytotoxic effect. And when you look at the mRNA expression of that, and we just combine the two outliers, so both are negatives, you see that there's a very little response to the immunotherapy, and when both are positive, so both interferon gamma and the PD-L1, you get a high response rate. So it understrikes the fact that you need the PD-L1, but you also need the effector immune cells in there. I will skip this one. Now, about the tumor-educated platelets was discussed this morning, but that had also been used as a marker for the effect of immunotherapy. So when you take these tumor-educated platelets and you look for a gene signature about the immune system, then you can also find that this may be predictive for the effect of immunotherapy. These are all early data, but it's really can be derived from the blood, so it's an easy to obtain biomarker. And another way of looking at this is by a protein classifier. So I'm not going into all the details, but there's a protein classifier has been generated, and when you look at the clinical effect of the drug, you can see that you can predict patients who will respond to the immunotherapy. And this is a slide about the imaging, and what you can do is you can label your PD-1, PD-L1 drug, you inject it into, this is the mice, and then see whether there is a binding of the drug to the tumor, so that maybe this can be a dynamic biomarker, how we can select patients for treatment so that you can make an image. When there is a binding, then probably there will be an activation, and the patients will maybe respond to this kind of immunotherapy. So to conclude on the biomarker story, the PD-L1 expression is best studied, but there are many questions do remain. Many candidate biomarkers are now into research, but none of them is ready for prime time in my view. And we are desperately in need for prospective clinical trials investigating this. And I thank you.